So I'm Dr. Brian Kaufman. I'm a family doctor and a doctor turned patient with CLL.
I'm John Pagel. I'm a CLL physician. I work at the Seattle Cancer Care Alliance, Fred Hutchinson Cancer Research Center in Seattle, Washington. Also appointment at University of Washington. Have a lab and do research in CLL. Have a clinic pretty much extensively devoted to CLL patients. Lots of clinical trials, lots of translational research. So I know a lot about, I think I do, a lot about CLL. Don't ask today about breast cancer or colon cancer. I'm not going to be able to help you. But maybe we could talk about CLL.
And you're a transplanter too.
Oh, and I attend on the transplant service and have quite a bit of experience, as we have at our center, with what we call reduced intensity conditioning allogeneic stem cell transplants for CLL.
So it's ASH 2012. We talked a year ago. What's happened in the last year? What's new, both at ASH and in your lab? What's new and exciting that the patient should know about, that the community hematologist should know about in the world of CLL?
Well, it's incredibly important. I mean, a lot of times when you ask that question to someone who comes to this meeting, you know, there's small incremental steps from one year to the next in CLL or AML or lymphomas, what have you. This year, from last year for CLL, it's game-changing. It is night and day different of where we're going and where we've come and what this field is evolving to. The landscape is really being rewritten, redrawn completely because of some new biologic therapies that I'm sure everybody's hearing about. The data here that's coming out at this meeting, really nothing short of game-changing. And what the game changer is that we're really now getting oral therapies or more targeted therapies, biologic therapies, and getting away, really evolving away from cytotoxic chemotherapies. The days of upfront FCR in every patient are coming slowly to an end. Chemotherapy will be now a second or third or fourth option, or actually maybe even not even an option, because of all these new biologic treatments that are really the buzz here. And frankly, we've had tremendous success and fun with these drugs, taking patients who are really, you know, run out of options for their CLL. Some with very bad biologic prognostic features, 17p or 11q, and these drugs have really taken them from a fairly dire situation to, in many cases, complete remissions and doing really well. So this is, for me, you know, of course, we're talking about cancer, no one wants this, but from a physician scientist, this is what we strive for. We're really changing the natural history of this disease by these new drugs that are in clinical trials now.
I think one of the advantages to these new drugs too is that their adverse events, their side effect profile is much, much better than chemotherapy. Is that a correct understanding?
Well, absolutely. So, you know, we'll talk about it, I'm sure. 3 major drugs that are oral pills that are clearly very active drugs, get people with shrinkage of their lymph nodes very rapidly, white counts get under control, and really with little to no toxicities. These drugs, even the intravenous new biologic drugs, the TRU-016 or GA101, these kinds of approaches really are associated without toxicity. Really well tolerated, and I think patients are loving that. You know, this is a really wonderful, amazing time. Not losing your hair, not missing time from work, not putting you at the risk of febrile neutropenia or life-threatening infections. All of those things are significantly reduced with these new agents.
So let's focus in on the ABT.
Okay.
How does that work, and what kind of efficacy are you seeing with that?
So this drug is, again, it's a pill. It's taken daily, and it targets a protein that I'm sure you're familiar with called BCL2, which is overexpressed on the surface of CLL cells. BCL2 is what we would call an anti-apoptotic protein. That means, of course, that it inhibits the cell from undergoing its normal programmed cell death. And so the cell lives too long. It proliferates, and of course that's what CLL is, or cancer, right? So if you can target that and inhibit that BCL2 expression, hopefully you could help or induce those cells to undergo apoptosis or cell death. And in fact, that's what ABT-199 does. It is a BCL2 inhibitor. It's an oral pill. It has really had some early, really nice results. A lot of that data is presented here at this meeting. There will be a significant oral presentation on it in indolent lymphoma. And what we're seeing is that there are people with bulky lymph nodes, really bulky lymph nodes, not only in CLL, but even aggressive lymphomas like diffuse large B-cell lymphoma that are getting remissions, white counts going to normal, platelet counts recovering. I have a patient, very first patient I treated with this drug, 17p deletion. She hadn't had her platelet count over 50,000 in about 2 years. Failed standard fludarabine-based regimens, FCR, these kinds of things. Now she's about a year out from starting that drug, ABT-199. She's in a complete remission. Her platelet counts are normal. She feels perfectly fine. Rides her bike 20 miles a day. Really changed her life, truly. So ABT-199 is a drug that maybe hasn't gotten quite as much play as the other drugs, but it will. It's another great drug. And the neat thing about it is this is going to be a drug that I think could potentially be combined easily with one of the other oral agents because they have different targets.
Well, and I want to go there, but let's talk a little bit about the other agents that are getting a buzz, and people are talking about ibrutinib and the GS1101. That's kind of the buzz in the patient population. Can you comment on that, what you're hearing here, your own experience?
Yeah, well, those drugs should be the buzz. They're also really outstanding drugs. There's no question about that. Ibrutinib, some people will call it Bruton's tyrosine kinase inhibitor. John Bird's presented some data here, or discussed a little of his data here, just really amazing, outstanding single agent results with that drug in relapsed patients, many patients with 17p deletions or 11qs. And that's a drug that is, again, an oral pill. It's very well tolerated. It's taken daily. And what it does is it targets a enzyme in the B-cell signaling cascade of the B lymphocyte, or the CLL cell, called Bruton's tyrosine kinase. So if you looked at a B-cell, on the surface is what we call a B-cell receptor that signals a whole cascade that goes to the nucleus of the cell, and that's important for proliferation, and actually is very important probably for the CLL cell to continue to survive. So if you can inhibit that pathway, you could have a major impact in killing those types of CLL cells. So this is a biologic therapy that targets Bruton's tyrosine kinase, again, daily, well tolerated, and seems to be a kind of drug that people could be on indefinitely. We don't know how long, right?
I saw something with Dr. Furman, who did some of the phase 1 trials, and he said he was frankly surprised at how well it worked because everybody thought it would bypass the pathways, but that hasn't been the experience yet with these new classes of drugs.
We haven't seen it. We haven't seen it, and I don't think we will. I mean, it gets to the idea is, will there be resistance to these drugs? And I suppose that will happen at some point, but we haven't really been able to describe that to this point completely. And it's very similar to the other drug that you brought up, which was GS1101. Some people call it Cal-101, which
the old name, yeah.
Its former name. Yeah. But another really special drug, pill, again, taken daily, and it targets another spot in that B-cell signaling cascade of the CLL cell. It's called PI3 kinase, and it's the delta isoform. And you could, again, get dramatic reduction in lymph nodes. Interestingly, what doctors need to understand a little bit, if you're not familiar with ibrutinib or Cal-101 is that when you first start taking the drug, lymph nodes will start shrinking, but the white count is going to go up, and it's going to go up dramatically. That's not a sign that the drug's not working or that the patient's progressing. In fact, it's probably a sign that the drug is working. We don't completely understand it. Perhaps there's some mobilization of these malignant cells to the circulation from, who knows, lymph nodes or other sanctuary sites. But over time, those counts, that white blood cell count, will come down to normal. So it will go up, but it'll come down, and patients will get nice remissions.